So I'm Cheryl Bushnell. I am currently the chair of the American Heart Association Stroke Council, and we've just come from a very exciting plenary session where we heard the results of the OCEANIC-STROKE trial. And so I'm here with Dr. Sharma, who is the PI for that trial, and we're very excited to have a chance to talk to you about the results. And I wonder if you could just kind of summarize that for us, and then I'll have some specific questions for you.
Thanks so much, Cheryl, and thank you for the opportunity. So in Oceanic Stroke, we randomized 12,327 participants who had either ischemic stroke or high-risk TIA within 72 hours of symptom onset. And they went on either asundexian 50 milligrams once a day, which inhibits activated factor 11A, or matching placebo. What we found was a significant reduction in the occurrence of ischemic stroke, which was our primary efficacy endpoint. The hazard ratio there was 0.74. And quite surprisingly and nicely, there was no increase in ISTH major bleeding, our main safety endpoint, and no increase in other types of bleeding, including minor bleeding, which we know from our conversations with patients as we're designing this trial is of great significance to them. So this trial resulted in the uncoupling of thrombosis, which causes strokes, and hemostasis, or bleeding, which is very pleasing to see.
And you had a somewhat of a difficult time enrolling women in this trial. I saw that there were 33% of the participants who happened to be women. I wanted you to talk about that, but I also noted that women seem to have a better benefit with a hazard ratio of 0.7.
Yes.
So I'd love to hear your thoughts on that.
So I think great points. So, in this trial, what we did was we actually exerted a great effort to include people who are underrepresented, including women. So there was a committee, which also included external experts in the field. We trained investigators to specifically go after these potential participants, and we launched a study alongside it to see if we could determine what made people want to participate and what didn't. That will be reported separately. What we saw was that the proportion of women in the trial increased most significantly in the US and Canada, slightly less in Europe, and much less of an effect in Asia. And this has been paralleled in other trials. Now, while the proportion was 33%, the type of patient profile I was looking for skewed towards people who were smokers, had dyslipidemia, and I think when we looked at the sex differences with that profile, we wouldn't expect women to be 50%. The nice thing with a trial this large is we do have enough women at a third to actually say something about it. And you're right, there was the point estimate for women was better even than for men. And I think part of this has to do with the fact that women were older. It seemed to us that they had less severe disease. And in terms of the vascular disease, though we haven't completely characterized that with sex differences. And I think there'll be a lot to explore there. But very nicely, unlike some other trials, including the initial aspirin trials, we don't have any concern with treating women.
I think that's really a wonderful kind of upside to the challenges with enrollment is that you still see a benefit. And I can understand with the Asian population that you often do see fewer women who are enrolled. The other thing I was really interested in asking you was about the first 90 days and stroke rates and for your outcomes and what you think the trajectory of benefit of reducing risk is early on versus later, and why maybe wasn't that benefit really clearly seen at 90 days?
So thank you for the opportunity. So, this trial had a window to initiate treatment of up to 72 hours. And in the first 24 hours, there were 600 people initiated. So I think that may be part of this reason. The other thing is that within 90 days, we had only 40% of the outcome events that we had planned for. So it's underpowered for that secondary endpoint. What we did do was on specified days, we looked at the number of events that occurred. And the earliest day in the time period was 15 days, and there already we see a separation. So more events with placebo than with asundexian. So I think it's a combination of these sorts of things that did it. Had we pushed recruitment very early, you may have seen a difference. I can only speculate as to what the result would have been. But, based on the biology, based on what we see at 15 days, the pattern of the curves, we think the effect occurs early and late. It just accumulates as time goes on. And so, those curves keep on diverging and you just get more and more benefit. So if you look at, for instance, the number needed to treat at 1 year, it's 53. If you look at it at 2 years, where we have our follow-up, it's 43. It's just a sign that those curves continue to diverge. And there doesn't seem to be any safety hazard. We looked at this even early. So with this data, we're not concerned that if you treat early, you will be in trouble in terms of hemorrhage and not receiving benefit. The benefit will be there, and the safety seems pretty consistent.
That's excellent. Kind of have you summarize what you think the impact on clinical practice is going to be, because the response to your talk during the session was obviously a standing ovation, and people are excited about a new option for treating patients. So I would love to hear your thoughts on how you think practice is going to change.
We're very excited about a number of things that are going to come in the future. It isn't approved yet, but we're going to move as quickly as possible to get it approved by FDA. So when we were planning the trial and we were talking to patients and patient groups, one of the biggest fears of stroke survivors was recurrence. And for, the first time in 50 years, we have something more than antiplatelet monotherapy, usually aspirin, that we can give these people, and without the offsetting hazard of hemorrhage. The other thing that's really gratifying in the data is you don't have to be very selective. We went up to an NIHSS of 15, did not see a differential effect by stroke severity, and likewise didn't see a different effect in stroke subtypes. So we think that this will be easy to use, apply to a large group of patients, and really have a big clinical impact. It's going to be, I think, wonderful to have something that can reassure patients, reduce their risk, and end up with fewer strokes.
I think that's awesome. I'm also just kind of, as you're talking about a new drug, wondering about cost.
So it's a great question, and if you think about what might limit prescriptions, what might limit usage, it certainly isn't safety, but cost will be an issue. I don't know what that'll be. I have no role to play in that with determining cost. But I think that that's going to be a very important thing. To get this into the hands of people to have an effect, you need to have it in a position where payers will cover it and it'll be available.
Yeah, absolutely. Well, thank you so much for participating in this interview. Congratulations again. And we look forward to all of the next steps with the medication and how we can help our patients.
Thank you so much, Cheryl.